Thank you very much, Dr. Adamson. I really appreciate the opportunity to speak about one of my favorite subjects, which is treatment of brain metastases, particularly in a multimodal setting like this. And I'd also like to acknowledge the help of a couple of my residents on pulling together some of the most recent data. My disclosures. We're going to talk today about some of the signs, symptoms, epidemiology, and diagnosis of brain metastases. Fortunately, the speakers before me have done an excellent job, and I'm really going to focus on the role of radiation therapy, particularly whole brain radiation therapy, contrasting that with stereotactic radiosurgery. We know there's lots of brain metastases, and they occur from almost any primary tumor. Who here has dealt with a patient with brain metastases in the last 2 months? Okay, vast majority. We know that it's very frequent symptomatically. It's also very frequent in autopsy, meaning that most patients probably do harbor some small number of cells that are going to eventually give rise to brain metastases, and that's particularly important as we get more successful at dealing with systemically, with primary tumors. Median survival is still far below what we'd like it. Certainly, even with the most modern therapies, typically less than 1 year. Whole variety of systemic presentations. Brain metastases can mimic not only primary brain tumors, but many other etiologies, including infection, including metabolic derangement. So there's really nothing that's pathognomonic for brain metastases. We've heard a lot about the recursive partitioning analysis. Again, just to point out that the patients that have the best performance status, typically that's the dominant factor. It's also going to carry over into some of the more refined methods for looking at for predicting the outcome, including the graded prognostic assessment. We at Duke participated in this multi-institutional study, the diagnostic-specific graded prognostic assessment. The thing to remember is when they look at the scores in this, unlike the RPA, a higher score is better when you're looking at the GPA. I just want to point out some things when we look at these survival curves. We can see that median survival time is significantly higher for patients with the best graded prognostic assessment, certainly much more so than patients that have the worst prognostic assessment, which would be the patients that have the poor KPS, that have more systemic disease. But let's just look at this. Let's look at the patients the patients 80% survival for a GPA class 0 to 1 versus a GPA class 3.5 to 4. The patients with the lower GPA might only have a median survival of 1 month versus almost 6 months for 80% would survive 6 months or more in patients with the high GPA. But it's also important when you're talking to your patients to look at that and consider the dispersion, the broad variation in survival. So if we look at patients surviving only the 20% survival, actually with patients, 20% of patients surviving with a GPA of 0, almost survived 6 months with a GPA of 0 to 1, versus a much higher percentage, 20% of patients with a GPA of 3.5 to 4 will fail at 6 months, will die at 6 months. So again, survival time is going to vary widely within a GPA class. So with that as background, let's move on and talk about radiotherapy techniques for brain metastases. We just look at the spectrum of treatment. There's certainly what I would classify as local therapies. Surgical resection, which Dr. Adamson did a beautiful job talking about, would be the classical local therapy. But then there's also stereotactic radiosurgery, which I'm going to describe in a lot more detail. And then what we call global brain therapies, whole brain radiation therapy, what we've employed for the last 30 or 40 years, and then potentially biochemotherapy, though the utility and the situations in which we apply that have yet to be established. Certainly we're looking more at combined therapies, surgery and whole brain radiation therapy, and it's important to also recognize when we should be providing supportive care alone. we think back to the previous slide that I showed, looking at the median survival time, particularly in patients with poor GPA, with the worst prognostic indicators. Sometimes the therapy of choice may be no therapy at all. And I think we also need to think about the point that Dr. Adamson brought up, that we must always ask, is this really a MET that we're seeing? Certainly when I look at MRI on a patient, we'll often see 1 to 2 millimeter ditzels, and we have to ask ourselves in that case, is that something we really want to treat, or is that something we should really follow closely? Sometimes they would even preclude a biopsy. If something looks unusual, even in the correct setting, I think we really need to be careful and consider and do this, again, in a multimodal approach and a tumor board, asking if this patient should undergo biopsy or should they proceed to some sort of immediate therapy. Well, in whole brain radiation therapy, we're typically immobilizing a patient in a mask to hold their head in the same position. We're applying radiation therapy from either side of the brain. We're excluding the anterior eyes. We're certainly excluding the lenses and most of the face. When people have historically done whole brain radiation therapy, we're looking at a range of 4 gray, typically administered over 5 days, up to as much as highly fractionated 2 gray per day for 20 days. Commonly, we're typically using now 3 gray times 10 days, or in my practice, probably more 2.5 gray times 14 to 15 days. There's really no level 1 evidence to support that one scheme is superior to the others. Now, in whole brain radiation therapy, we're trying to minimize toxicity by fractionating the radiation therapy or breaking the radiation therapy up into multiple treatments. In stereotactic radiosurgery, we're really employing a different paradigm. While we're still using externally generated ionizing radiation, we're minimizing damage and we're minimizing toxicity by applying radiation therapy to only the lesion itself. In this case, we're going to have several things that need to be in place in order to do effective radiosurgery. We're going to have to utilize high-resolution imagery to precisely define the size and location of the lesion. It's going to have to be done through a multidisciplinary team. I never treat a brain metastases without having a neurosurgeon who's an intimate part of the team, as well, of course, as a medical physicist. And while we typically would perform radiosurgery in a single session, we may perform it up to 5 sessions, particularly for larger lesions. And there's a variety of techniques that can be used to do this. I think one of the things that's moving more into practice and that allows us a lot more flexibility right now is the fact that we not only can immobilize patients in a fixed head frame, but we can also put them in a mask and then image them at the time of treatment and then use this image guidance to precisely position and reposition the patient. It's like one of the abstracts talks about being able to do single isocenter multi-target, and that's clear that you need image guidance to do that effectively. Well, again, there's a large variety of radiosurgery systems out there. There's Gamma Knife, the Cyber Knife. I'll talk a little bit more about what we do with linear-based accelerators, but basically all apply the same basic principles we saw before. In our radiosurgery system, we're using a high dose rate linear accelerator to generate the beam, and we're utilizing cone beam CT and orthogonal imaging to be able to precisely make sure that the patient is set up exactly correctly. We have several different systems for doing that. We're able to, once we image the patient, it wouldn't do any good to say, well, it's just the patient's 1 or 2 millimeters off, or rotate it a few degrees if you couldn't correct it. So we're typically employing a 6-degree of freedom table to correct that position. And again, that's essential if you're doing multiple targets in the brain. And we're finally shaping the beam using a high-dose micro-multileaf collimator. And of course, we're using very sophisticated planning software to be able to precisely and accurately calculate the dose and deliver the optimal dose plan. Typically what we're doing with whole brain radiation therapy, we're using a mask, a thermoplastic mask that's fit to the patient, molds it. For radiosurgery, we're typically using a mask that has a couple unique features. Most importantly, it's got relatively rigid plastic that's still, again, molded to fit the patient over the philtrum, over the bridge of the nose and the forehead. When we look at a lesion, we're looking at the anatomic location, the size. We're precisely and accurately drawing out the lesion on multiple slices. We'll utilize typically for smaller lesions, we'll use multiple radiation beams called dynamic conformal arcs, in which the head of the linear accelerator sweeps around the patient, but the pivot point for all those beams is precisely in the middle of the lesion we're treating, and you essentially wind up with precisely shaped dynamic conformal arcs that deliver a very tight dose distribution. And there's various techniques for doing this. I think functionally, whether using a gamma knife, a cyber knife, or another linear accelerator-based system, you're coming up with functionally a very tight dose distribution, and you want to make sure that it's accurately delivered. Well, how did we come up with the doses we use for stereotactic radiosurgery? RTOG 90005, so over 20 years ago, they asked the question, what's the maximum tolerated dose? They looked at patients with not only single brain metastases, but also patients with recurrent gliomas. They found that, which is always sort of surprising, but maybe not so when you think about normal toxicity, you'd like to think that you could be able to give more dose to a bigger tumor. Unfortunately, as the tumors get larger, as the metastases get larger, you have to use smaller doses. So typically the teaching is for metastases less than 2 centimeters, we're going to tolerate 24 gray. Some people deliver 20 gray because they feel that's enough. Others can argue that it can actually be a little bit higher. 2 to 3 centimeters, 18 gray, and 3 to 4 centimeters, 15 gray, though more of us are doing fractionated stereotactic radiosurgery on larger tumors. Let's look at some clinical outcomes. I'm not going to repeat all the data that you've seen before, but clearly one big question initially was, does surgery in combination with whole brain radiation therapy have anything to offer whole brain radiation therapy alone? And as Dr. Adamson pointed out, clearly surgery and whole brain radiation therapy, in this case of single brain metastases, offered superior overall survival, lower rates of neurologic death, and I don't want to jump ahead on you, lower rates of neurologic death. And I think most, at least in our practices, when we feel that surgery is appropriate and there's a single brain metastasis, particularly if there's mass effect or there's any question about the diagnosis, we're always, as radiation oncologists, I always recommend that they consider surgery, and they often do go to surgery. You can also look at postoperative radiation therapy for the treatment of single metastases to the brain. Again, another randomized trial from Dr. Patchell. They randomized these patients with a single brain metastases to surgery plus or minus whole brain radiation therapy versus whole brain radiation therapy plus or minus surgery, which you saw previously. Well, the results of this, that recurrence of tumor anywhere in the brain was dramatically less frequent with whole brain radiation, the addition of whole brain radiation therapy, about 20% versus 70%, and that was both at the site of the tumor itself and at other sites in the brain. And again, the whole brain radiation therapy group was less likely to die of neurologic causes. They saw no significant difference in overall survival. So patients with single brain metastases who get surgery typically will be recommended to get radiation therapy. Now, we won't talk a lot about this today. We're also thinking we also do probably more these days, treatment of the postoperative resection bed as opposed to just whole brain radiation therapy. The data is less strong on that. Now, the EORTC asked a similar question. Does adjuvant to whole brain radiation therapy versus observation offer a benefit after radiosurgery or surgical resection? So applying, again, a global therapy after these local therapies. So these patients were with 1 to 3 brain mets after surgery or radiosurgery were randomized to observation or whole brain radiation therapy. The primary endpoint in this case was deterioration. I think one of the underlying things in this study was that perhaps they would see a survival difference in one arm versus the other. Well, there was no difference in time to performance status deterioration, and also no difference in overall survival. They did see a reduced 2-year local relapse with whole brain radiation therapy versus observation. So that's very consistent with the earlier Patchell study. And 2-year distant brain metastases with whole brain radiation therapy. And again, the whole brain radiation therapy group was less likely to die of intracranial progression. Okay, so again, it's certainly, whole brain radiation therapy certainly reduces intracranial relapse and the rate of neurologic death, but doesn't increase the duration of functional independence and overall survival. And again, you'll hear this theme I talked about when we talk about radiosurgery alone, is the question is this an advantage or a disadvantage for whole brain radiation therapy or radiosurgery? Well, we do know, one of the things that I always tell my residents is you cannot just sweep the whole effects of whole brain radiation therapy on the rug. It's important that patients know they're going to have the cosmetic effects of hair loss, scalp erythema. Sometimes they can have severe fullness in the ears, parotid swelling. In the already debilitated patient, further anorexia and increased fatigue can be devastating, causes them going a downward spiral. So that has to be well managed. Now, the long-term side effects of whole brain radiation therapy, though, are probably more controversial. Certainly go back to Dr. DeAngelis' paper back in 1989. They found 5 of 47 patients treated with whole brain radiation therapy for a single brain metastasis developed dementia at 1 year. But of these patients, many of them received a relatively high dose per fraction and or radiosensitizer. And none of the patients who were treated with less than 3 gray per fraction developed dementia. Today we're typically, again, using 2 to 3 gray, though we can go to higher doses per fraction in patients with very short life expectancy. And again, we need to think about those patients received just supportive care alone. RTOG 0214, looking at prophylactic cranial radiation, showed that PCI, even at a low dose per fraction, was associated with decline in Hopkins verbal learning tests. So my personal observations, most patients receiving whole brain radiation therapy are going to develop mild cognitive deficits. I think it's important that they know that that is an effect of whole brain radiation therapy, and that some, but very few, will develop severe cognitive deficits. Now, we also know that brain metastases, when they recur, have an adverse effect on cognitive function, and that patients that have distant failure of brain are going to undergo salvage therapy. So you have to be careful when we're talking about avoiding the effects of whole brain radiation therapy. One of the benefits of whole brain radiation therapy, it does decrease recurrence in the brain. And the question is now, how does that stack up versus things like radiosurgery? I'm not going to go, in the interest of time, I'm not going to go into RTOG 9508 in detail, but this was a study looking at whole brain radiation therapy plus or minus stereotactic radiosurgery. A beautiful job by RTOG at randomizing these large numbers of patients. Survival in subgroups of patients was significantly improved with the addition of radiosurgery. It was seen statistically improved survival was seen in patients with single brain metastases, in patients with a high performance status, and patients with large brain metastases, as well as certain histologies. Toxicities were relatively low, and addition of stereotactic radiosurgery decreased to whole brain radiation therapy, also decreased the rates of recurrence. Performance status was typically improved compared to the group that got, comparing the group that got radiosurgery to those that just got whole brain radiation therapy alone. And the group that got stereotactic radiosurgery in addition to whole brain radiation therapy showed more radiographic responses. So just the take-home message from this was we see that stereotactic radiosurgery would increase survival in patients with single brain metastases, large brain metastases, RPA class 1, and favorable histologies. It can actually improve KPS compared to radiosurgery alone. It can produce more radiographic responses, reduce edema and steroid requirements, and again, you have to think of that in comparison to whole brain radiation therapy alone. What about the flip side? Does emitting whole brain radiation therapy compromise efficacy, increase recurrences, increase or reduce survival? Does it reduce cognitive dysfunction? Does it improve the quality of life? ACOSOG trial, which we participated in, failed to accrue adequate numbers of patients. The Japanese study by Dr. Ayoma did succeed in accruing a sufficient number of patients to whole brain radiation therapy plus radiosurgery versus radiosurgery alone. What they found was that there was no significant difference in overall survival in patients receiving radiosurgery versus whole brain radiation therapy, radiosurgery. Whole brain radiation therapy, not surprisingly, significantly decreased distant recurrences, also appeared to improve local tumor control, though I've got some questions, and we'll talk about that briefly, about why that might be, and it may appear to improve local control. There was no significant difference in neurocognitive function, though this was measured by a mini mental status exam. Now, MD Anderson, over a period of 8 years, conducted a trial, again, a similar trial, looking at patients randomized to radiosurgery plus or minus whole brain radiation therapy. The primary endpoint was neurocognitive decline. They found a significant difference between the patients who received radiosurgery alone versus those who received radiosurgery plus whole brain radiation therapy, with a significant benefit in reduced rates of neurocognitive decline with those receiving neurosurgery. I think it's important to point out that there was really a surprisingly poor, unexpectedly poor outcome in whole brain radiation therapy. And I think we need to consider that when we look at the results of that trial. We've completed a trial which is coming out in the next couple of months in the Red Journal, looking at radiosurgery alone, looking at rates of, looking at the impact of expanding the tumor volume. Typically, when you're treating a patient with radiosurgery, you're contouring out the contrast enhancing lesion on T1, and you may add 1 millimeters, 2 millimeters, 3 millimeter expansion around that in an attempt to improve local control and hopefully not impair toxicity. So this was a study we looked at, took 80 lesions, randomized to 1 to 3 millimeters expansion about this, used a dosing we discussed before under RTOG 90.005, the increasing dose with decreasing size of the tumor. We enrolled 49 patients in this trial at Duke. Relatively high performance status, but of a range of histologies and a range of tumor diameters. When you look at I apologize for this sort of mind-numbing slides, particularly after a heavy lunch of truffled macaroni and cheese, but what you notice is that there was no difference in the gross tumor volume between the two arms, but obviously the lesions that were expanded to a larger extent were larger, and that the dose to these lesions, the dose cloud about these lesions receiving 12 gray, which is typically a marker of potential neurotoxicity, was larger in the larger expansion group. We saw a median overall survival of 10.6 months. At the time of analysis, 15 of 49 patients were alive. We looked at mini mental status exam, and also trail making A and trail making B. We saw no significant difference over the 3 months of treatment. I don't have it on this slide. We looked at FACT-BR, functional assessment, cancer therapy in brain tumor patients. Again, no difference after 3 months. Though it's important to point out, when we looked at this, many patients, a lot of patients had died even in that 3-month period, and it was obviously in a patient that's very sick, they often refuse to go out and do this testing. Patterns of failure. What was striking on this, we saw only a local recurrence rate of about 6 or 7%. Now, I got to say, other people are also reporting numbers to this effect. Definite local recurrence was observed in only 3 lesions, and 2 of these were on biopsy-proven imaging. One biopsy-proven in a single patient with esophageal metastases, and one was based on imaging alone, but by the criteria of the study, we had to consider that a local recurrence. No significant difference between the 1 and 3 millimeter groups. Distant brain metastases was very high, as you've seen in other studies. observed in 24 patients at 9.7 months post-radiosurgery, and radionecrosis alone was observed in 6 lesions. So actually the rate of radionecrosis, all of which was biopsy proven, was actually higher than the rate of local recurrence. And these were predominantly in the 3 millimeter group, though didn't reach statistical significance. So we look at what we saw in this study, the freedom from local recurrence was extremely high with radiosurgery alone. But again, you have to think about, I think it's very easy when you look at these patients to see a radiographic change and have your radiologist almost all the time tell us suspicious for recurrence of disease. And the approach that you're going to take if you have true recurrence versus radionecrosis, or I prefer the Pittsburgh term, adverse radiation effect, is going to be different. And what you tell the patient is different. I have stopped several patients in this study from going on for whole brain radiation therapy because we insisted on a biopsy, and essentially with steroids, their adverse radiation effect was self-limiting. It's just important to point out that other studies have shown higher rates of local recurrence, and I'm almost done, Dr. Adamson. Higher rates of local recurrence, and again, I think that's because of the way that we interpret the imaging on this. So my observations, in at least the way that the radiosurgery was performed in these cases, local recurrence was relatively uncommon. That certainly the technique appears very accurate, and the concern that we had about tumor extending far beyond the contrast-enhancing T1-defined lesion appears not to have been founded. Distant failure is very common and must be monitored closely. Rate of necrosis or adverse radiation effect was higher than what we saw for local recurrence. Certainly, I think it was not statistically significant, but certainly was more trended toward the higher rate with a larger margin. I think you need to be very careful about judging recurrence, and you need to biopsy or observe these patients or resect them before treating for recurrence, for example, with whole brain radiation therapy. And attack brain metastases, at least again in our system, 1 millimeter margin appeared adequate, and there's no compelling reason to use a much larger margin. And then you have to have excellent QA to be able to do that. Well, what's the consensus on this? Well, there isn't a consensus yet. Whole brain radiation therapy and radiosurgery do offer the best control. Whole brain radiation therapy offers improved rates of distant brain metastases. Certainly there's less acute side effects with radiosurgery alone. There's no clear survival advantage by adding or omitting whole brain radiation therapy, and no clear cognitive advantage or disadvantage to adding whole brain radiation therapy based on our current studies. Though clearly we do know that whole brain radiation therapy does have adverse cognitive effects. And you have to consider the patient's particular circumstances and preferences before deciding on what is the optimum treatment. Emerging issues, SRS, the post-op resection cavity, is actually very widely employed right now. We need more data, and we need to be able to select the correct patients. We need, there's more technology emerging on it to be able to irradiate a large number of lesions with radiosurgery. Certainly it's got much easier, much more effective. You can use, I described the University of Alabama, the single isocenter multi-targeted approach, or with automated repositioning and gamma knife. But you have to consider, if you have a large number of brain metastases, are you missing a small number? What is the correct number? What are the correct prognostic factors to be able to choose those patients? Hippocampal sparing obviously works at sparing the hippocampus and improving memory. This is, again, essentially when you're applying whole brain radiation therapy, but sparing not treating the hippocampus, or treating the hippocampus to a much lower dose. I think you have to ask, is that efficacious and cost-effective, or efficacious versus whole brain radiation therapy or radiosurgery? I think that there's probably actually a very small window in my mind where I would actually employ that. And finally, I think the biggest question on the horizon is biochemotherapy, immunotherapy, small molecule therapy, probably in combination with whole brain radiation therapy. I think effective chemotherapy that penetrates the brain is probably the best, maybe the best global therapy, and whether you do it with or without radiation therapy, or with or without whole brain radiation therapy, because it's effective global therapy, it may take the place of whole brain radiation therapy. I think that's where a lot of promise lies in the future. So thank you very much. I apologize for running over a little bit of time. I'd like to thank my colleagues, particularly those in neurosurgery, our patients, and you for your attention.